It's a real privilege to be with you today, and Lieutenant Governor and Paul. You guys have so much to be proud of in North Dakota in terms of the transformation you've had over the past few years. About 8 years ago, I moved from the upper Midwest. I was next door in Minnesota to New York at our corporate headquarters in IBM. And I took my cat into the veterinarian, and my wife and I went to try to find a primary care provider, and my cat got notified because my cat had a registry that it needed its immunizations, but me or my wife weren't notified. I asked my primary care provider at the time, do you know how many men my age, 55 or above, have not had their colons scanned, and how many women 55 or above have not had their breasts examined? And he looked at me and he said, Paul, I don't know how many women are in my practice, let alone how many have not had those procedures that are needed to be done. And you see, for us as a buyer of care, for corporations or government that buys care, only about half of the recommended services that need to be bought or provided in the current delivery system. You know, the follow-up and the follow-through. And what I see happening here in North Dakota with giants in the land is that you've really stepped up to managing a population and thinking about managing a population in a much more effective way. You see, we as human beings, we think when I meet with a group of docs and talk to them about the care that they deliver, they will oftentimes tell me, well, I tell the patients to do the right thing, but they don't do it. And the fact of the matter is that for us in healthcare, it's much more than throwing a dart at a target. Particularly now with about 80% of our cost being chronic diseases that have to be managed, when you take a human being and you try to manage that human being, you're throwing a bird, right? Because between when you have them for that 5 minutes that in your office, if you're seeing 30 a day, and the time that they get to their target, they've flown in multiple directions. And in order to manage that, you need the skills, the understanding around how you manage a population and you manage chronic diseases much more effectively. And here in North Dakota, in MediQHome, you've begun that journey. You've taken simple solutions like MD Data Core, the technology that allows the docs to put information into the system and then fed back to them as insight about how effectively they're managing the population, so that you see the women who don't have their breast exams now get notified that they don't have their breast exams, and the men that don't have their colon scoped and the women that don't have their colon scoped get notified, and we have seen about 230% increase in the number of diabetics who are getting their eyes examined, and we're seeing an increase of about 150% of those colons that weren't scoped. By the way, those are real lives. I mean, that represents a significant number of folks who are now alive who wouldn't be if those simple things weren't done. I can tell you that with sincere personal experience, in that we did find a medical home in New York. We worked on it for 7 years in our community, and now most of our docs are in a medical home like here in North Dakota. And my wife was notified that she needed a breast exam. She got her breast exam. Something was actually there that shouldn't have been there, and she ended up being treated, but it was early enough that her prognosis is really good. So it means real things. At about that time, I was visiting some of the large academic medical centers on the East Coast, and I drove to one of the largest academic medical centers, famous name, and as I was driving down the freeway, to visit that particular academic medical center, there was a giant sign on the freeway, and the sign said, "We do the best heart surgery in the country." I went into that academic medical center. I met all the O's, the CEO, the CFO, and I said, "I know exactly what that sign says. That sign says we know where the money is and we're going after it. That's not the sign I want to see. I want to see a sign that says we do the most effective coordination of care. We have the most robust primary care, that you will need 1/3 less heart surgery. And by the way, we have places in the United States, and you guys are now becoming one of those places where that actually happens." And that's not rocket science, you guys. That's ABCs. That's aspirin, blood pressure, cholesterol. That's effectively understanding that you have a population that you need to manage and stepping up to manage it. So there are three things that are driving this trend towards a medical home, MediQHome. One is unsustainable cost, and we'll talk about that for a minute or two. But if you look at this particular graph, it's a fascinating graph because it looks at 15 years of life from age 40 on, and it tells you how effective the healthcare delivery system is, both in years of life lived and in cost. And the United States is dead last, and we're dead last at twice the price. But if you look a little bit further at the slide, you'll see that Fargo, North Dakota isn't so far up as the entire United States. In fact, you know, we're pretty close to Switzerland. So, you know, in this country, in the past few decades, we have evolved a system of delivery of care in which we probably do some of the best partialty care in the world. And when you hear people talking about we have the best healthcare system in the world, to that extent, they're probably correct. In fact, you know, we have had medical tourism come into our country for a number of years because the Yakuza from Japan will come here to get their kidneys transplanted. We do really good hips, we do really good knees. But the fact of the matter is that our employees will oftentimes have 5 partialists, 5 specialists, all working on a different part of the body with no adult supervision, nobody coordinating that care, nobody integrating that care. So what you're doing here is stepping up to that issue, right? Just stepping up to the issue of how do we integrate and coordinate care, and how do we deliver care of a much better value. So for folks like employers, when we look across the country, we look at cost of healthcare as one of the major indicators of where we want to put our jobs. In fact, last night I got a call from Ogden, Utah, talking about a large employer that's looking at putting 4,000 jobs in Ogden, Utah. I can tell you, you know, we have data now, right? We've been putting our data in a data warehouse now for 10 or 11 years, and we begin to understand these issues of cost, and healthcare is our second most expensive cost. So it isn't just about doing the right thing for your citizens and delivering the best care at the best value, but it's about your jobs in the long run, because, you know, I don't think there's a lot of people that are going to move to Anderson, Indiana. I mean, you know, just looking at the data, right? So the Department of Defense and other federal agencies have done this as well. They begin to look at cost. And again, cost is one of the things that's driving this trend. And this is a graph that they gave me a few weeks ago. And at about the time of 9/11, we took much of our in-house healthcare that was delivered by the military, and we outsourced it through TRICARE into the civilian market. They call it the DoD Medicare purchase. And there's that line that goes straight up into the sky. And it's now 10% of their total budget. If you look at the Veterans Administration, they've actually been below the Consumer Price Index. And by the way, when you survey employees, when you survey folks who have access to multiple systems, people who get care at the VA are now the happiest. So what the DoD is doing is insourcing their care back to the VA and insourcing their care back to medical homes that they're building in their community. It's having a huge impact. I visited a hospital in Chicago where they've taken the military facility, the the VA facility, and combined those. And I visited a medical home that the Army built in Savannah, Georgia, which has eliminated 95% of the encounters against the local emergency room because they have access 24/7. So they're beginning to look at, just like us as employers are, the military is as well. The other trend that's driving this change, and it's driving it very rapidly, is data. You see, tools like Watson are going to do for the doctor's minds and for the consumer's minds what X-ray's done for our vision over the past few decades. We tried to control cost a few years ago, and some places are actually pretty effectively doing that. I mean, you've got Kaiser as an example, but we didn't have the data then. We now have the data. We now can take information using tools like MD Data Core that Blue Cross Blue Shield of North Dakota is using, get information from the doctor's office, begin to sort that information out, and send it back to the doctor's office's insight so they can act at that data, follow up and follow through with their patient, right? So data is the other thing that's driving it. And the last of the three things is a real change in communication. And the last time, the last big communication change, cultural change we had was the automobile. First we had doctors that could drive to the patients, and then the patients got the cars and could drive to us. But that's dramatically changing. No longer do we have to see the whites of a patient's eyes to begin to engage them, follow up and follow through with them, to be the nagging nurse, to be the continual reminder, to put tools in place to get through. In fact, in visiting Kaiser recently, 41% of their encounters are now asynchronous or not face-to-face, and it's becoming more effective, much more effective. So my kids, who are 25 and 30, have never seen a teller at a bank. They never intend to, right? They do a lot of their stuff online, and that's the third thing that's driving this, a real change in the way we communicate. So if those three things are driving this, right, if we've got cost, we've got data, and we've got communication change, what do we need to do to make this change effective and work for us? And there are three things we've got to do. We've got to change how we design our benefits. So if I have a $20 co-deductible and you can go anywhere you want with that, I mean, it doesn't do much good for you. It doesn't change the cost structure. If I change it and I put skin in the game and, I ask my patients to wear a pedometer, and they wear a pedometer and they get low prices on their benefit design, and I begin to reward them for doing the right things, then, we begin to see change. My wife, when she needed that procedure, I called around the various hospitals, the various facilities in my community to understand the cost of the facility fee for a mastectomy. And the variation in price was from $2,700 at an ambulatory surgical facility to $38,600 at the local hospital. And that's the variation just for the facility fee, right? So you design benefits around valuing the place that delivers the value. And by the way, the quality was actually better at the cheaper place, and that's oftentimes the case. So benefit redesign. You need to put skin in the game. You need to expose the patients to an understanding of cost if you expect them to respond to cost, transparency of cost. We have to change the delivery system to design and follow up and follow through with our patients. The example of a registry and following up with mastectomy, the example of having a care coordinator follow up and follow through with our diabetics so that they manage them, right? So that's tremendously important. So the other thing that has to happen is you've got to pay them differently. If you continue to pay only fee for service, you'll get too much services. Report out in the New York Times, today in the Wall Street Journal, I've seen 57 of them in the past 2 weeks talking about this very issue, right? Talking about the fact that 43% of the stents that are put in are unnecessary. you know, all sorts of studies show that about a third of what we're spending money on that doesn't add any value. So you begin to need to develop a delivery system, a payment system, and a benefit system that synchronizes and cadences together, delivering a much better value proposition. So what's the fundamental foundational unit? What's the necessary system integrator that allows that to happen? The Institute of Medicine came out with a report last week that said the only thing that can do that is a robust base of primary care, and that robust base of primary care has to interface with public health, right? It has to interface with health and prevention. It has to be the system integrator that allows that to occur. So MediQHome is that, right? It's the place where, at the level of the primary care provider, data goes into the system, and when data goes into the system, something happens to that data. It gets held accountable. You see, whenever you have data, something magical happens, and there's an expectation of the buyers that somebody's going to be held accountable to that data, right? Outcomes. You begin to pay for better outcomes. You begin to pay for better quality, and you stop paying only fee-for-service, which is what MediQHome is beginning to do. And that's why we're seeing an 18 to 20% reduction in ambulatory sensitive conditions using hospitals. So the model of care that we're in now is called the Flexner model. It's where the doctor is the data storage repository unit. Information goes in medical school, and at the level of the delivery system, it's regurgitated, and they're a master builder. That's all changing to an entirely different model. You see, healthcare is the last economy, the last business, the last gasp of that master builder model. We no longer build skyscrapers doing that. We have a plan. We have data. That's what's happening in healthcare and happening here in North Dakota is every patient has a plan. You know, they have data, right? They follow that data. It's no longer a doc with everything in their heads. It's a team of patients doing the right thing for the patient, looking at that data and delivering a much better value proposition. And patients aren't shortchanged in this system. I visited a number of practices that do this. The patients love it. Same-day access. You know, their iPhone gets their laboratory results. Follow-up and follow-through that's profoundly changed. But look, you guys, I mean, we're seeing 60% less complications of our diabetes. Right here in North Dakota, 60% less. That's 60% less amputations. That's 60% less people going blind, right? Because somebody's following up and following through on the ABCs. I mean, that's Zsa Zsa Gabor with a leg to stand on. So, MediQHome, right here in North Dakota. I mean, it's the right care. It's going to deliver it at the right price and at the right time now. The now is really important because, you know, those of us who are buyers are asking the plans to give us this, right? The federal government as an employer is asking for this. Medicare has 7 pilots around this. You know, this is the care that we have to have. You know, no longer am I willing to buy an episode of care. No longer do I want to go to a place that has a focus on, you know, we do the best heart surgery. I want to go to a delivery system that has a focus on we do the best coordination of care. We follow up and follow through. You're going to have 1/3 less need to do heart surgery, but when you have to have the heart surgery, we do the best heart surgery, right? Does that make sense to everybody? That's what you want in North Dakota. Thank you very much.